good morning, good afternoon, depending where you are on the world. It's a big pleasure from my side to welcome all of you again, probably again, because it's the third webinar in a row of uh, regarding the topic of cardiopulmonary exercise testing. And because we received so many questions, more than 100 in total, we tried to summarize them. And I'm happy to introduce again Professor William Stringer, Professor of Medicine from the David Given School of Medicine at UCLA, to try to go through most of the questions you raised in the first two webinars. And at the end, so we try to schedule again 1 hour. The presentation will take less than 1 hour. So at the end, there will be an interactive part again. So feel free to ask your questions already during the webinar. And my name is, you see it in the first slide, Herman Groepnhoff. I'm the Senior Clinical Scientific Advisor from Biomedical, and happy to be involved in this kind of very important educational webinars on different respiratory diagnostics topics. And now we have CPET. So please, Professor Stringer, take over and start your webinar.
Yeah, thank you, Herman, and thank you all for joining. So what Herman and I tried to do was to summarize the different questions into categories, and I'm going to go through those on the slides. But if you have questions, go ahead and put those in the chat box, and we'll try to address those as we get in there. This is sort of the standard disclaimer, and these are my disclosures. I think the most important one is I'm involved with a CPET book. I work at Harvard UCLA in Torrance, California, but I'm involved with exercise practicum teaching as well as a textbook. Okay, so there was a question about biological calibration versus a metabolic simulator. And so they're both trying to get at the same question, which is how do I make sure that my system is accurate? So on the left up here, you have a protocol where you're actually doing 3 minutes of rest, 3 minutes unloaded cycling, and then 25 watts for 8 minutes, 50 watts for 6 to 8 minutes, and 75 watts for 6 to 8 minutes. And you want those all to be below the lactate threshold so that the slope of this line will be 10 mils per watt. And the step up should be 250 mils of oxygen uptake for each one of these steps. So you analyze that towards the end of each step, and just making sure that those are average so that you get a number that against predicted values. So you got a slope, and then you're comparing the steps, and you're comparing the absolute number at 25, 50, and 75 watts to predicted values. So that's one way to do it. And I recommend trying to do that at least once a quarter, once every 3 months, on somebody in your lab that is regularly there, that you can compare prior responses to. But the flip side of that is what we call a metabolic simulator. So it has a piston, it has a volume, and then the beauty of this system, and this is the reference here, European Respiratory Journal, it's back in 1990 with Huschek. This system is basically describing this, but the beauty of it is it's 21% CO2. So 21% CO2 plus 21% oxygen makes an R of 1, right? And so you know that the R has to be 1, plus you can check the volumes at different flow rates. So you can go for a low flow rate at early exercise, a high flow rate at end of exercise. These are not cheap, but most companies have them, and they can be rented. I recommend not buying them, but they can be rented and used. Usually it's done when the system is first set up, but it can be done if you've changed equipment or have some questions about the accuracy of the system. But the biological calibration doesn't require this type of equipment. It can be done with just individual in your lab. So that's the beauty of that. Okay, so that's kind of biological calibration versus metabolic simulator. Okay, there were questions about how to use the ventilatory thresholds in determining exercise intensity and training. So this article here is actually a really good article. It's British Journal of Sports Medicine in 2022, Descensi. I recommend pulling it and reading it top to bottom. So what they try to do is the lactate is on the y-axis and the percent VO2 from low to high is on the x-axis. So at very mild intensity, obviously the lactate's low, you're below the first ventilatory threshold. And we talked about this before, but that can be called the AT, the LAT, the gas exchange LAT, VT1, whatever you want to call it. It's really the first deviation between mild and moderate exercise. So your lactate begins to go up after your ventilatory threshold, your Borg scores go up. And if you like either percent heart rate or percent VO2 peak, those are listed here as well. And finally, on the bottom is essentially what the lactate is doing here. So we're between phase 2 and phase 3, you have the second ventilatory threshold, VT2, which is your respiratory compensation point. I'm going to go through how to pick those again, just to make sure that everybody's comfortable with that. But those occur somewhere between lactates of about 3 and 5, and then greater than 5. Borg scales are going up higher, relative perceived exertion, percent heart rate, percent VO2, etc. So this is one way to think about it, just in your mind on a one slide, how it works. Now, going back to the ventilatory thresholds, remember the AT is where this 45-degree line. So you've set up this CO2 output and the oxygen uptake with the same size axes and the same scales from 0 to 2 or 0 to 3, whatever. And so this 45-degree line here is essentially 10 mils per watt. And what it's telling you is that this deviation here occurs when there's additional CO2 output that's not metabolic. So the R of 1 here is your metabolic production, and then this is anaerobic production or excess CO2 from acidosis. So that's VT1. VT2 is respiratory compensation point. So you put ventilation as a function of CO2 output. You draw a line in the initial part of it, and then when there's additional stimulation of ventilation relative to CO2 output, meaning there's some other source of hydrogen ion, that's where your respiratory compensation 2. So if you go back to this and you want to know where ventilatory threshold 1 and 2 is for that individual patient, you can do that as a percent VO2, you can do it as a percent heart rate, and you can give them a design and exercise prescription that will help them individualize their actual therapy. So I'm just going to talk about this very briefly, because there was a lot of questions about what this is. They really all the same thing in my mind. They're trying to reflect the same physiologic phenomenon, but there's lots of different names for this. I usually use AT, but whatever you like to call it, it's fine. It's on a lot of the systems, it's called VT1, which sort of gets away from the first ventilatory threshold. So any of those is fine. But again, remember the slope of 45 degrees here. When CO2 output begins to accelerate relative to oxygen uptake, going down to panel 4, you can actually see the ventilatory equivalent for oxygen starts up when ventilatory equivalent for CO2 is either flat or going down. The open boxes here, oxygen, are ventilatory equivalent for oxygen, and the closed sort of blue circles is the ventilatory equivalent for CO2. So that point should be the same as that point. And then going down further into panel 7, and that's part of the reason that panel 1, 4, and 7 are in line, is you can see the end tidal oxygen goes up at the time the end tidal CO2 is stable. So all of those are gas exchange manifestations of the V slope. This is called the V slope method of picking the AT. This is called the gas exchange method of picking the AT. Hopefully those all align, but sometimes in patients they don't. So you have to make some decisions about what's actually going on physiologically, especially if the patient is not a regular breather. That makes the data a little bit more difficult. So anyway, that's VT1. The VT2, we already talked about it. What you're going to see is on this ventilation as a function of CO2, this is a slope, and the VEV-CO2 slope is important in a lot of diseases. I'm going to show you that in a minute. But it's where there's additional stimulation of ventilation relative to CO2 output, and that's called the respiratory compensation point, or VT2, or whatever you like. It actually, if you can go down to panel 4 and panel 7, it's where you would start to see the ventilatory equivalent for CO2 start up, which is this blue here. So it had been pretty level. This is back here in VT1 when the ventilatory equivalent for oxygen went up. This is where the ventilatory equivalent for CO2 starts up. That's also consistent with respiratory compensation. And then finally, this is when the end tidal CO2 begins to be driven down. So all of those should be characteristics of the second ventilatory threshold, or the respiratory compensation point. And this is the gas exchange method. This is a sort of a V-slope method of trying to get a hold of VT1 and VT2. Okay, so who cares, right? So this is a great article, Agostoni's group in Milan. They took a whole bunch of patients, well over 2,000 patients, and they looked at outcome. This is 5-year outcome. So if you could find an AT and a respiratory compensation point, so VT1 and VT2, they had a really good outcome. If you just found the AT, it was less, but it still was okay. And the third one, if you couldn't find an AT or a respiratory compensation point, they had the worst prognosis. And that's sort of a combined outcome of death, having a cardiovascular event, or having some revascularization. So all of those outcomes were much less if you had both of those identified. So it is important, especially in the heart failure literature, why you'd want to identify R. And then comparing those numbers over time is important too. Okay, so there was another question about slopes of the ramp. So when you put somebody on a bike, you can adjust the work rate per minute, depending on what the patient's current sort of exercise level is. And that's part of the reason I sit down and I talk to them about, do you walk regularly? Do you run regularly? Do you go to the gym? How much time per week do you do? And then I try to set up a work rate that goes from sort of very low, which might be 5 or 10 watts per minute, up to very high numbers, maybe 20 or 30 watts per minute. I rarely use 50, but they did that in this study to show you the difference. So it doesn't really make a whole lot of difference what ramp slope you pick in terms of maximum heart rate, in terms of peak oxygen uptake, or peak of AT. That's not really what changes. What changes is, so the peak oxygen uptake in those 3 different ways is very similar here: fast, medium, and slow. It's sort of like the Goldilocks of different ramp rates. But if you look at the RER at end exercise, the RER in exercise at that 50-watt ramp was much higher than the RER at the slow ramp, which in them was 20 watts. So if you use an RER value of, say, 1.1 to say that the patient reached a maximal rate, you can see that you would actually be at the end of this test. You'd be in the middle of these 2 tests, right? So you don't want to pick an RER value and say, okay, the subject can stop exercising now because they reached an RER of 1.1 or 1.05, because depending on what you picked for your ramp rate back here, these are high ramp rates because these are normals, but even in a patient, make this 5, 10, and 20 watt ramp, you're going to get different RERs at the end of exercise just based on how much CO2 comes out in that short period of time relative to distributing that CO2 output over a much longer ramp. So hopefully that makes sense. So hopefully you won't be using an RER to stop a test or to decide if it's a maximal test or not. You want to go back to the other cardiovascular variables, heart rate, oxygen uptake, AT, et cetera, to really understand the test. Okay, there was another good question about, like, what's the highest measured oxygen uptake? And this has to be tempered a little bit. We do data processing for pharmaceutical companies that are doing cardiopulmonary exercise testing at different sites. So we might have 50 or 60 sites in a study. And I can't tell you for sure that all of those oxygen uptakes are measured exactly the same way. So you might wonder, if you got a really high number in a peak oxygen uptake, whether that was well calibrated. And that was really the focus of the first seminar, was trying to decide if your lab is working well. And that's part of the biological calibration. But anyway, if you believe these numbers, and again, this comes out of this topendsports.com, you can take a look at it. This Oscar Svedmanson had a oxygen uptake of 97.5 mils. This one is also very similar, 96, and that works out to be 7.3 liters per minute, which is a very high, a very high number. You may not recognize these other people in here. Maybe you do. This Bjorn Dale is a Norwegian cross-country skier, so they're using both legs and arms at the same time. They had very high numbers, 90 mils per kilo. Greg LeMond is actually the only American cyclist that still has the Tour de France yellow jerseys. The rest of them have been busted for drugs. But you can see up here that Miguel Indurain was also measured very high. Chris Froome, 84, and Lance Armstrong in the 84 range. So it's not all just oxygen uptake, but the size of your engine relative to the chassis, so that's mils per kilogram, is important. So you can increase the size of the engine, or you can decrease the size of the trailer that you're taking up the hill. And that's what happens during the Tour de France, which is coming up in July. So you may ask the question, okay, what about women? Here, the Joan Benoit was a distance runner. She was measured about 80 mils per kilo, obviously very fit. And these are some of the other, some more recent, some back a ways, but somewhere between 60 and 80. So a world-class athlete has an oxygen uptake that's probably in the 60 to 80 mils per kilo. If you're looking at high school versus college versus professional sports, you'll see that those numbers continue to go up because they become very fit. And they obviously have a genetic gift as well, but they practice at whatever their sport is as well. Anyway, so that top end sports, you can take a look at that if you're interested in this. So you can find your individual person. If there's somebody you want to look up, they'll be in there if they've been tested. But if you could test all these people in the same lab with a very well calibrated system, you could tell whether 97 is different than 92 because these are all different labs measuring oxygen uptake in lots of different ways, lots of different analyzers. Then I'm always a little suspicious of the numbers, but clearly these people are very gifted in terms of their oxygen uptake. Okay, so we kind of talked about this already, but there was a bunch of questions about when do you stop the test? Well, I mean, obviously, if there's some concern about medical issues, you want to stop the test. Usually that's blood pressure, and I use about 220 over 120. And if they're getting close to that, but their physiology looks good, their VO2 work rate still looks good, et cetera, their EKG still looks good, I might let them go a little bit more. But I think 220 over 120 is a good number for your technicians. If they get up to that level and there isn't a physician in the room that can say, okay, it's okay to continue or not, then that would be a good time to stop. I wouldn't use heart rate peaks or percent heart rates, like 220 minus your age. So say you're 60 years old, 220 minus your age gets you 160. If they hit 160, you want to stop the test. No, you don't want to do that. You want to let them go as long as, you know, the oxygen uptake, you've got a lot of gas exchange variables, you've got saturation, you've got the gas exchange variables and the 12-lead EKG at the same time. You've got a lot of information about whether they're safe to continue or not. So the heart rate alone wouldn't stop me. But again, remembering that there's lots of people that are on rate-related agents, and so their heart rate may never hit a certain number to stop a test. Beta blockers, calcium channel blockers, et cetera. And the same thing for Borg scores. Some people get to the end of a test and they give us a Borg score of 2. Remember, it's a rating between 0 and 10, or that's the modified Borg, or the unmodified Borg is 6 to 20. And a lot of people stop the test and say, okay, by the time you get to a Borg of X, you should stop. I wouldn't do that because everybody's Borg perception is different. And so if the patient looks like they're struggling or uncomfortable or whatever, that would be important to me. But a specific number on the Borg score isn't anything I would do anything about. So there was another question about how to do the Borg scores during the study. And so what we do is we have a card, it's a laminated card. It's from 0 to 10. We talk to them about before the test, you know, that we're first going to ask them about their perception of dyspnea. And then the second question will be about their leg fatigue, and have them just point at what's actually going on. So if you hold it up in front of them, they can point to it. They don't have to talk. And they can also use their fingers, you know, if it's 1, 2, 3, 4, 5, it gets a little more complicated after that. But that's another way to do it. Pulse oximeter change, I think, is something that you should pay attention to. If somebody's reliably running below 85%, I would say stop the test. If they're a known patient that desaturates, say a pulmonary hypertension patient with a shunt, and sometimes they go down into the 70s, and you're comfortable with that, I would say that you would need a physician in the room to be comfortable doing that study. What I would do is look at the prior studies, if they've had prior studies, to see what their saturation did. But below 85%, I think you're in thin ice there that something may happen that's not good for the patient. So 85% is probably a good number. If they sustain that over a short period of time, 30 to 60 seconds, I probably would stop the test. Otherwise, they could go down further and they might stay down. On arrhythmias, rare unifocal PVCs and not increasing in number is not worrisome, but doublets, triplets, obviously VTAC, those kind of things, the more complex arrhythmias are the ones that you'd want to stop the test for. And you want to actually document those, have a continuous running EKG so you can show those to other people if there is complex arrhythmias during exercise. It's not all that common, but it does happen. And then, if the patient's having a problem with a joint or a cramp, then you basically have to stop the test because you're not going to get a good test out of it because it's now being limited by musculoskeletal things. And you may want to bring them back on a different day or switch to a different ergometer. Maybe you go to bicycle from treadmill or treadmill to bike or an arm ergometer or something so that they can still do an exercise test if that's important for their patient care. So my recommendation is to encourage the patient to continue until they can't keep the revolutions, the cadence of the bike above 50. And that's a reasonably good way to decide when to stop the test. But your lab, depending on what your standard operating procedures, you want to make sure that you keep the patient safe, but you have a lot of data that's streaming by you during a test, and that's really going to help you keep you out of trouble if you're paying attention to that information. So it's important that you can see the patient, you can see the patient's eyes, you can see the 12-lead EKG, and you can see the gas exchange while you're doing the study. That should all be in your line of sight somehow in your laboratory, and that keeps the information fresh and in front of you as you're trying to decide how the test is going. Okay, there was a bunch of questions about systolic versus diastolic heart failure, and unfortunately, we're not going to put the echo people out of business. You're still going to need an echo to know what their ejection fraction is, but what I'm going to show you is heart failure, whether it's preserved or reduced ejection fraction, has obviously difficulties with pumping blood. That leads to VQ mismatching, meaning that the blood flow relative to ventilation is very high. So the Q is low, the V is high, and they have mismatching in the lungs. And so that leads to an abnormality of dead space. It also leads to acidosis and a high ventilatory equivalent relative to their work rate and dyspnea. That's one side of the exercise limitation. The other one is the perfusion problem, excess lactate from the tissue, reduced ATP regeneration in the muscle, impaired muscle function, and then fatigue and dyspnea from that. So all of those are true, whether it's systolic or diastolic or preserved or reduced ejection fraction. But you can actually quantify on CPET the class of heart failure from none, which is greater than 20 mils, all the way down to severe, which is less than 10, or very severe, less than 6. And so that can be done either with the peak oxygen uptake, and it can also be done with obviously measuring the cardiac output, but it also could be done by the size of the anaerobic threshold. So above 14 is considered normal, less than 4 is very severe heart failure. So these are ways to classify heart failure based on oxygen uptake. But in terms of deciding what's going on with either preserved or reduced ejection fraction, this is a really good article. It goes all the way back to 2003, but old articles aren't necessarily bad articles. But I don't know if you've ever read Dr. Seuss and the Grinch. But remember, the Grinch's heart was 2 sizes too small. I don't know if you remember that, but I'll come back to that in a minute. So Dr. Seuss was a noted cardiologist. So this is normal variables of heart function. This is left ventricular end diastolic volume. It's about 120 mils. Left ventricular end systolic volume is about 50 mils. So there's 70 mils that come out in the stroke volume. And if you take that 70 mils divided by the original volume, which is 120, you get an ejection fraction of 60%. And for a heart rate of 60 with a stroke volume of 70, you get 4.2 liters of cardiac output. Okay, so that's normal, 4.2 at rest in a patient. Okay, so let's go to systolic heart failure. So the left ventricular end diastolic volume is much higher here. It's 250. And the end systolic volume, because there's poor contractility, is still 200. It's markedly higher than normal. But the stroke volume here is about 50 mils. And if you take 50 mils times 60 heart rate, so we're going to keep that all the same, you come up with 3 liters of cardiac output. So already the cardiac output is reduced even at rest in these patients. But what about preserved ejection fraction or diastolic abnormalities? So the heart actually is smaller than normal. That's the two sizes too small. So the end diastolic volume is low and systolic volume is low relative to normal, and certainly relative to heart failure and systolic heart failure. But again, if you take 50 mils times 60, you get 3 liters. So this is just an abnormal cardiac output. It's low. It's about 30% below what it should be, but it's because there's different characteristics of the volumes of systolic heart failure versus diastolic heart failure. So take a look at Dr. Andrews' paper here. It's well done. I've gone through this maybe a little faster than you want, but taking a look at this table and sort of the more you think about it, it's more sort of a Zen moment about what's going on with heart failure in somebody that has a pretty good ejection fraction, right? The diastolic, the preserved ejection fraction is 60% here. So what's wrong with their heart? It's really that their stroke volume is quite small. And so they have to have a lot of beats. And then the faster the beats are, the less time in diastole there is to fill that ventricle, that very stiff ventricle. So that's where the heart failure comes with this. And obviously with systolic heart failure, it's really the contractility problem. And so you still have a very low ejection fraction, which is this stroke volume 50 divided by 250 comes down only 20%. Okay, anyway, enough about that. So what about CPET and ejection fractions? So this is people below and above 50% in this publication by far. You can see the New York Heart Association isn't any different in these low and high ejection fraction patients. So that's not going to separate you. Most of them are on goal-directed therapy and could have beta blockers and ACEs these days. And then if you look at their echocardiographic characteristics, these people average an ejection fraction of about 50, or excuse me, about 30. These average about 60. And the same characteristics we saw about the end diastolic and systolic volumes are occurring here in that paper by Andrews. So very similar population here. So when you exercise these people, you end up with a lot of very similar numbers, heart rate numbers, the oxygen uptake numbers, etc. Ventilatory equivalent numbers are actually very similar in these patients. So if you told me this CPET is somebody that has reduced ejection fraction and this patient has normal ejection fraction or high ejection fraction, I would be able to tell you they have a low peak oxygen uptake, they have a low AT, it looks like there's a cardiovascular abnormality, but I couldn't tell you whether it's preserved or reduced ejection fraction. So you're not going to be able to separate that. You're going to be able to quantify that in terms of the exercise limitation, but you're not going to be able to say that it's systolic or diastolic heart failure or it's preserved or reduced ejection fraction from the CPET. Okay, so okay, what about what we call oscillatory breathing? Sorry, the thing's flickering there. So oscillatory breathing is where you see periods of very rapid breathing and then very slowed breathing, and it just goes in an episodic way. It's more common at rest, but it can persist into exercise too. And so this was about 500 patients that Dr. Guasi did, also in Milan. Took a look at them and either preserved or reduced ejection fraction, and they both had about a third of them had oscillatory breathing at rest, which is obviously a pretty bad sign. What you can see is if you have what he called diastolic heart failure or preserved ejection fraction, those people have the best outcomes up here, and this is over about 5 to 6 years, something like that. Maybe 7 years, actually. If you have systolic heart failure, it's a little bit less here. But then if you have either diastolic or systolic heart failure plus oscillatory breathing, you see that those have the worst event-free survival, and that's a combined outcome as well. So oscillatory breathing is something you should pay attention to during exercise testing in a heart failure patient. It means that their prognosis is not good. And a lot of those people have some kind of outcome that's poor even in the next 12 months after the CPET. So it's important that the cardiologist or whoever you're doing the study for knows that they have oscillatory breathing, and they probably need to increase the intensity of their therapy or move to a different therapy, because this oscillatory breathing is definitely a worrisome sign. Okay, there was a lot of questions about VDVT during cardiopulmonary exercise testing. And depending on how much blood you actually draw during studies, you may be more comfortable with this. We're moving, I think, towards less invasive studies. So I think it's good to have just something in your mind about what should the VDVT do as the work rate is increasing here. It should fall to a nadir, hopefully below 0.3. At the anaerobic threshold. I tend to take the number right at the anaerobic threshold. What's the VDVT at the anaerobic threshold? In my mind, it should be less than 0.3. Honestly, it should be less than probably 0.25 to 0.20 in a normal person, and it can get down as low as 0.1. And then some patients actually go up in a bowl type shape, and then some are flat like this. So it's basically telling you that their VQ matching is getting better here as the work rate increases. So the dead space to tidal volume ratio is actually coming down. So what does that mean in terms of gas exchange? So if you have a transcutaneous CO2 monitor, you'll be able to see the arterial CO2. But if you draw a blood gas, like say you draw a blood gas right around the anaerobic threshold here, you can actually see that the end tidal value that you're reading in your system should be above the arterial value. What that means is the arterial minus end tidal value is negative, meaning the end tidal is higher than the arterial. And so that's a normal VDVT. So if you see this during exercise, you can be pretty assured that they're going to have a normal VDVT. However, if you take somebody with lung disease, either obstruction or restriction here, what you'll see is the end tidal never gets above the arterial. So there's a lot more wasted ventilation here, a lot more dead space in these particular patients. And so a normal response to exercise is this: at rest, and this is actually as a function of time here, what you can see is with each breath, the end tidal should go above the arterial. That little dashed line is the arterial. And the arterial is driven down during heavy and very heavy intensity exercise, like we showed before, but the end tidal should actually stay above that. It gets steeper, the breaths get shorter, but the end tidal should still be above the arterial. So that's why we use a transcutaneous on our studies routinely. And I recommend it. It's not a cheap piece of equipment, but it's a very helpful piece of equipment in trying to decide what the VDVT is during exercise. And so remember, the components of a high ventilatory equivalent are either a low arterial CO2 or a high dead space, or both. And so it's helpful to be able to eliminate a high VDVT as the etiology of a high ventilatory equivalent. Okay. This is actually a nice article that I'd recommend, Levenezia. It's back a little ways, 2018, but just talking about the way that A and C here would be normal sort of resting and further into exercise. And this would be somebody with either COPD or interstitial lung disease or something else where there's still a very large difference between the arterial and the end tidal, and meaning that the VDVT is quite high in this group. So that's a nice summary of dead space ventilation during exercise. Okay, there were some questions about how do you set up a 9-panel. All the commercial equipment systems will do whatever you want. Pretty much, you just pick a montage. My only recommendation, I mean, obviously, this is the montage I use fairly commonly, but it doesn't matter what the montage is, but just make it the standard for your lab so that when you see a study from today and you see a study from 6 months from now, it's easy to compare those visually, and you know what you're looking at in each one of those boxes. So remember, the top boxes here are what I call cardiovascular outcomes. So it's time or work rate on the x-axis and oxygen uptake and CO2 output here. So rest, unloaded cycling, all the way up to peak exercise and recovery. And we also put work rate on there. And importantly, we put the work rate at 10 mils per watt. So 4 liters of oxygen uptake is 400 watts. So that this line is 10 mils per watt. And you can see very quickly that oxygen uptake is paralleling that. So it's a normal VO2 work rate relationship. Next one is heart rate and O2 pulse here. O2 pulse is the open red, and this is the darker circles here is heart rate. And then this is the V slope, just like we showed on those other slides. In terms of gas exchange variables, this is ventilation as a function of time or work rate. This is ventilation as a function of CO2 output, and that's where your respiratory compensation is going to come from. Respiratory compensation point, sorry. And then this is tidal volume as a function of ventilation, just telling you how deep the breaths are and what the respiratory pattern is during exercise. And then finally, these are the gas exchange variables. This is ventilatory equivalent for oxygen and CO2. And remember, we picked the AT here. You should draw a line down and see if the ventilatory equivalent for oxygen is going up when CO2 is stable. You can see it is there. That's a pretty good AT number. And then you want to see the end tidal oxygen going up at the time the ventilatory equivalent for CO2 or the end tidal CO2 is stable. And then this is the RER value. This person was bouncing around a little bit, maybe anxious, but there's an R value at end exercise of 1.3. And it looks like they did about 240 watts in 10 minutes. So this is a 20-watt ramp. Anyway, so there's a lot of information condensed into a very readable format, but just pick a format that you like. And in your head, when you see a CPET, you'll know what should be in each one of those columns. It always makes it a little different if somebody comes from a different lab and shows you a different montage. It'll take you a minute to sort of flip, but that's okay. There was a bunch of questions about what do you do with athletes. Athletes are tough because they tolerate dyspnea. They push themselves. They want to excel in whatever sport they do. So the equations for athletes are challenging, but this actually was a fairly recent study where they came up with essentially predicted values for athletes. So you can take a look at this, see if it helps you with understanding the athlete versus the patient. I do more with patients than athletes, but I like the way this was done. So what they did was they have cycle and treadmill here, and they put down essentially their observed oxygen uptake. And you can see, let's say at age 40, their predicted oxygen uptake is almost 4 liters in these patients. Now, see these little lines down here, these little colored lines? This is where I live. I use Washington predictors, but Jones predictors are good as well. But you can see for a 40-year-old person, that predictor is only about 2.8. So this is predicting for patients. This is predicting for athletes. So when a patient comes into your lab and they're an athlete, they're regularly exercising, and they come up to normal values for your predictor in your lab, and that really should trigger something's wrong with that patient, because athletes should not be hitting normal predicted values for patients because they're much lower than what you see in athletes. Same thing here for treadmill. 40-year-old person should be doing, looks like about 4 liters. And you can see this is, again, quite a bit lower. And that's Wasserman and Jones for treadmill. So good article. I'd pull it and read it and see if it helps you. If it helps you, that's great. If it doesn't, I don't know what to tell you. I mean, these numbers, I think that athletes comparing to themselves is probably more important. So if you did a study on somebody and then repeated, say they did some training, they did something else, excuse me, and they come back for another CPET, they're probably their own best control rather than trying to look at predicted values for athletes. But they do exist out there. And I like the way this article actually compared them to what I would call patient type predictors. Okay, hope that's makes sense. So finally here, this is a slide I showed. I think it's important to kind of have in your mind. We talked about the the identifying factors of things like COPD, heart failure, pulmonary vascular disease, peripheral vascular disease, obesity, and long COVID. We went over that in the second seminar. But I think it's a good idea to have in your head, what should be going on with peak oxygen uptake? What should be going on with AT? What about breathing reserve? What about ventilatory equivalence? And what about some other miscellaneous things that might help you understand that? So that's pretty much it. Herman, I'm happy to turn it back over to you if you want to take a look at any of the questions that may or may not have come in while we were going through that. And hopefully that made sense. And it was meant to be answering some of the questions specifically that we had gotten from the first two seminars. And Herman, you might be on mute. I can't actually hear you. Yeah, well, that's it now.
Oh, no. Okay, again, thank you for this nice and quick overview of a lot of questions already. And yes, we have already a few extra questions, so let's do this. And I like this interactive part, so I read them for you. And at the end, if necessary, I also have a few questions, but there are already questions. How does what that's selected for the bike ergometry compare with use arm ergometry? We use Wasserman equations to estimate bike work. Would it be the same for arm?
No, arms and legs are obviously quite different. I don't know right offhand if there's good predictive values for arm ergometer. It's probably going to be there probably is data in the literature. What I would do is search for predictive values and arm ergometry. But that being said, again, I think the patient is going to be their own best control. And there's much earlier generation of lactate using your arms rather than your legs. They have different muscle fibers, different biomechanics, and they're actually affecting your chest wall as you're doing it. So you're breathing and you're actually, doing arm ergometry. So there's lots of reasons why predictive values might be complex in that group. If that's a thing that you normally do, there may be predictors in some of the manufacturers' predictive values. That's worth taking a look at, depending on what system you have. But I don't know if you know, Herman, if there's anything inside of the VIR system that actually has predictors.
No, I'm not aware that we have them in, and I'm not aware that there should be somewhere in the literature. So I'm happy to get the response for people who are searching for this, but no.
Yeah, sounds good.
Okay, another question, of course, again, I want to encourage all of you. I see there are still 160 people, and I would not recommend to go over 100 questions again, but there are still 6. It cannot be true that any of you don't have any extra questions, but there's somebody who like you to review again a little bit more about how to detect the anaerobic threshold. There's a little apologies, he missed the beginning, so maybe you can quickly go over again VT1, VT2.
Yeah, so that's easy. So the thing that you're going to look for in the first ventilatory threshold, well, what we talked about earlier was this article is a good article summarizing the intensity of exercise in this direction and the ventilatory threshold 1 and 2, lactate measurements, Borg measurements, percent heart rate, percent VO2. This is a good article. I pull it and read it cover to cover. But if you want to know about AT, you're basically going to put the CO2 output and oxygen uptake on a equal axes and equal numbers, and you're going to use a 45-degree line, which in any of the computer systems you can do visually on screen, move that around. And where the CO2 output begins to increase more rapidly than oxygen uptake, that's your VT1. Your VT2 is your respiratory compensation point. So you're going to put ventilation versus CO2 output here. CO2 output and ventilation are linear as you get up to a certain number, and then it becomes more rapid ventilation increase relative to CO2 production. That's your respiratory compensation point. That's VT2. So I hope that makes sense. And then we talked about the gas exchange manifestations of a ventilatory threshold, meaning the ventilatory equivalent for oxygen goes up when the ventilatory equivalent for CO2 remains stable, and the end tidal oxygen goes up when the end tidal CO2 is stable. What it means is ventilation is tracking CO2 output. Ventilation is not tracking oxygen uptake, and that's why the two differ. And the same thing when you get the ventilatory threshold 2, this is the same thing we just looked at, but if you go to the other two, panel 4 and panel 7, what you can see is that this is when the ventilatory equivalent for CO2 starts up, and that's the respiratory compensation point, not the anaerobic threshold, but the respiratory compensation point. And then the same thing, this is when the end tidal CO2 begins driven down relative to stability in the area of oxygen, the anaerobic threshold. So that's the quick and dirty. Picking ATs is always a little bit challenging, but I encourage you to do it and talk to each other about why you picked that particular number. And you get better at it very quickly, visually, and also the systems are very good about picking these. And if you don't like what the system picked, and I'd always review what the system picks, it could be right, but it also may not be right. You may not like that number, to move it around dynamically so you can have all your reports reflect the AT that you're most comfortable with.
To be sure, and I want you to have it said, so if I understand you correctly, you should never take only one graph. You compare, you use the feedback from more than one graph for both slopes. That's the benefit of the to having all this data in different graphs.
Yeah, absolutely. You know, you have what a V-slope method, which is more of a Wasserman type method, and you have a gas exchange conformation, which is more of a whip type method, Brian whip. So you want both of those to coincide if possible. They don't always, but they should be very close. And so I agree with you, Herman, that you've got so much information that you don't want to rely just on one number. You want to confirm that in other graphs and other physiologic data.
Then we have a third question from my colleague Keith from the US, and I would like to have it also said by you, and I recognize, I think it's the same with Keith. We get a lot of questions from via how good it is to get VD, VT from non-invasive measurements, so without the blood gas. And I saw you explaining all regarding to arterial blood gases. Is it really necessary to have an arterial blood gas, or can we do without it?
Okay, so let me just get to one slide here.
So the question from Keith was, what should we do with the absence of an arterial line or transcutaneous?
Yeah, so all of the commercial CPETs report a VDVT using the end tidal. And so that's what the problem is. They may use a Jones correction to try to correct the CO2 to make it more like the arterial rather than the end tidal. But just look at this graph. So this is the end tidal. This is the arterial. The arterial is the gold standard. That's where you do the Bohr-Inghoff VDVT calculation. Using end tidal is essentially approximating that, either using the actual number or a Jones predictor that's trying to make it compensate it. But it works in normals because they're very similar to each other. It doesn't work in patients because the end tidal is different than the arterial in patients because they have abnormal dead spaces. So if you can take it off the report, I would do that. I mean, I know it's strong words, but it's not accurate. What I would do if you have a large difference between the arterial and end tidal on a non-invasive test would be to actually do an invasive test and confirm it, because the transcutaneous CO2 does have some limitations, but it's a nice way to do things non-invasively and not to stick the patient. But one blood gas right around the anaerobic threshold when the patient's not struggling will give you an excellent VDVT calculation. So if their end tidal is very low, or there's lots of ventilation during that study, I would seriously consider about getting at least one blood gas in mid-exercise and not use the calculated VDVT from the systems using end tidal. It's going to be inaccurate. It's going to be wrong. And you want, obviously, the highest quality data to provide your the people who refer to the CPET.
I'm happy with your answer. Of course, it's not that we, I can only speak for myself, from VIA recommend to do it, but we put it in because we get the question. So totally agree, and I assume Keith has the same opinion about this. But you say you only know the difference between end tidal and arterial if you have both. So if you only take into account the end tidal, you don't know how wrong you are.
Yeah, so you're absolutely right. But what I would say is if you're looking at an end tidal that's low in the early parts of the test, not at the end, because the end tidal does get drive down at the end. Early part of the test, low end tidal, I would actually stop the test, get ready and draw blood gas, and then restart the test, because you're going to know that that end tidal is going to be abnormal relative to arterial, and you want an actual number. The other thing is, if they're at rest and their minute ventilation should probably be about 6 or 7 liters, and unloaded cycling should be less than about 10 liters so let's say they're in unloaded cycling, they're doing 15 to 20 liters of minute ventilation. From that alone, you know that there's excess ventilation, there's excess dead space. And depending what their end tidal is, that would be another indication that you're going to need an arterial CO2 to figure that out. Why is there so much ventilation at very low work rates? So at the start of the test, look at the amount of ventilation they're doing, look at the end tidal CO2. You're not constrained to not think during a CPET, right? If you look at data and it's not making sense, or you're going to need more information to make that data make sense, stop the test and do something else, or bring them back and do a study that draws blood, because that is the gold standard, and everything else is an approximation. I think transcutaneous is a better approximation, but it's not perfect. It does have time constant issues, etc. So I draw blood. It's if you can't do it that day, then bring them back and do moderate exercise the next time and draw blood gas during moderate exercise. It's all you need right around the AT.
Yeah. Now again, you come back to this point. I think you already explained it the last time. Don't do the arterial blood gas 30 seconds too late, and now you even make the statement you can do it halfway. That's
Yes,
already good.
it's a really good point. So if you're fussing around with the blood gas at the end of exercise and they happen to go into recovery, the gas exchange kinetics in recovery are crazy. The R value, oxygen drops very quickly, CO2 output drops even slower. And so you don't want to draw it at the end, because first of all, the patient is struggling, pushing, whatever, and it's going to make them either stop concentrating on the test or whatever. Better to do it in mid-exercise. One blood gas in mid-exercise, I'd be very happy with. If you can put an arterial line and draw it throughout exercise, that's great too. Or if you don't have the capacities, refer it to some other lab where they can actually draw blood. But it is the gold standard. I guess that's all I can say. And sometimes you just have to do it to try to really figure out what's going on with the patient.
Next, so you covered the arterial blood gases, dead space, more than enough. Is it necessary to do adjustments, compensations? I guess regarding reference values for people with a very high body weight, with a high BMI. I know Wasserman has this high weight corrections.
Yeah, so some of the predicted values have weight in them, some don't. I recommend to use one that does have weight in it, because obviously our population is increasing in weight. But what I can tell you is that we report both. We report the oxygen uptake per minute per kilogram, and then we report it as ideal body weight in kilograms. So essentially, it tells you if that person had a normal sized body, what would be the oxygen uptake in mils per kilo per minute, and what their current weight is in mils per kilo per minute. And some people like to see one like to see the other. What I usually tell other people at practicums is that I like the one that actually is related to their actual weight. So let's say, for instance, it's a preoperative evaluation and you want to see their peak oxygen uptake. And so remember, a peak oxygen uptake of 20 mils per kilo per minute means that they'll probably do very well with upper abdominal and thoracic surgery. So let's say that person is very heavy and their mil per kilo per minute is only 15. But the actual oxygen uptake is pretty high, but their weight is pretty high too. So that's what's drawing that number down. Are they going to have an outcome that's more related to 20, or are they going to have an outcome more related to 15? So what I say is that the patient has to get up from bed with their actual body, not their ideal body after surgery. So I think that that's the more important number clinically is actual weight, but we do it with ideal too, because what the ideal tells you is how do they compare in terms of fitness compared to normal size individuals. So people that are obese frequently are actually very fit. It's just a lot of their energy is used to move the internal components, and you don't get a lot of external work in those people. They're still able to generate a lot of heart and lung capacity, but they use a lot of that energy just to move the legs to move around. So that would be my take on it. Put both of them on your report and use the one that's the actual patient most of the time, because that's what they have. The patient has to deal with their body as it is right then.
Okay, thank you. Does long COVID resemble the CPET of a myopathy problem? So,
Well, that's interesting. Yes, there are some mitochondrial abnormalities with long COVID that's being explored. Some of the complexes are abnormal. But the majority of CPETs in long COVID show that their oxygen uptake's a little down, their AT's a little down, their work rate's a little down, and they look like a deconditioned individual. So that's the majority of them. There are a subgroup that actually has what they call dysfunctional breathing, and that means they have sort of erratic changes in their tidal volume, their ventilation. Sometimes they're driving down their end tidal CO2. They seem to have additional stimulation to breathe that's not metabolic related, so coming from the CNS, whatever. And so the average pattern in somebody that has long COVID is just mild reductions in AT, peak oxygen uptake, and they look deconditioned. But the myopathic, there are groups that have either small nerve or muscle inflammation. And those patients can actually have very severe exercise limitation. And they can also have autonomic abnormalities and what they call postural orthostatic tachycardia or orthostatic changes. So you want to make sure that the patient that you're recommending to do CPET on is okay in the vertical position and wouldn't have trouble with that. So if they do, you can use a recumbent bike. That's another way to get around it so that they're semi-recumbent. Or you can actually do a test looking for orthostatic hypotension. One of those tests is actually what they call a NASA lean test. You have the patient just lean against the wall for basically 10 minutes. You can measure their blood pressure, measure their heart rate. And if they have a drop in heart rate or a drop in blood pressure, an increase in heart rate or a drop in blood pressure, that tells you that they have orthostatic changes. And if they don't have that over 10 minutes, they don't. So a NASA lean test is a way to get at autonomic abnormalities in patients with long COVID. Anyway, I think the question is good because long COVID is not a unidimensional disease. There's multiple organs that can be involved, multiple different organs, and multiple sources of exercise limitation. So don't try to pigeonhole them into one category. They may have some degree of myopathic abnormalities. They may have some degree of orthostatic or vasoregulatory problems, and they certainly are deconditioned because they don't feel good and they're not doing their regular exercise routine. So exercise training is one of the ways that we're trying to improve that, but there's certainly groups, especially the people that have orthostatic abnormalities that shouldn't be doing exercise, at least in the vertical position. And they should be doing things like pacing and other things that allow them to modulate their exercise, their energy across the whole day.
okay, thank you. If I listen to you, we should have a webinar dedicated to CPET related to COVID, probably. Can you
Yeah.
please review changing the slope range that you mentioned previously? So I assume, of course, on what part of the slope you should draw your slopes.
Yeah. So I think it's good to do this on screen. I like being able to move the around, but I also like to print it sometimes and just have a blow up of just the panel 3 and just put a little 45-degree angle on it and move it around. But either of those two will help you with the slope. On a commercial system, you just move this around. For the respiratory compensation point, what you'll see is you can restrict where that line is drawing the line is being drawn. So you don't want to draw it all the way up to the top here. You want to draw it and constrict it into this area so you can see that that's where it's linear and then it's nonlinear. So some heart failure studies actually use all the way up to the top, and some cut it off right at the respiratory compensation point. But the slope here, let's say the slope is 29.5. If you go all the way to the peak here, you're going to have a higher number for the the slope of the ventilation versus CO2 output. So you just have to make sure that it's being measured the same way. It's good to read the methods section of the CPET article to see whether they measure it right at the slope at the respiratory compensation point, or whether they go all the way to the peak, because you'll have a higher number up here. The slope, I can't do it on screen here, but you just imagine that going up into there, the slope is going to be higher. It doesn't matter which one you do. I actually think the respiratory compensation point is the right one, but as long as you're homogeneous in the way that you approach it and always report that the same way and have your technicians draw that line in the same way, then it'll be fine.
A question about dynamic hyperinflation. Can you review how and when you parse out ventilatory abnormality from the exercise flow volume loop, other than the determination of exercise and exercise long volume?
Yeah, so it's a great question. So dynamic hyperinflation just means that you don't have enough time to exhale completely down to your FRC. So your FRC is where the lung wants to collapse, the chest wall wants to expand, the two are in equilibrium, right? So as you go up and up in terms of lung volumes, your FRC, you're not returning to your FRC, you're staying higher. And that's what we call dynamic hyperinflation. So you can actually do this to yourself. Take a deep breath in, let out half, take another deep breath in, let out half. It only takes about 2 or 3 breaths, and you're actually very uncomfortable. That's the feeling that they have during exercise. That's dynamic hyperinflation. So how do you assess that? I think the optimal way is inspiratory capacities. So basically you have them tidal volume breathing, and you have them take a deep breath and then exhale normally. And you do that 2 or 3 times at rest and unloaded cycling so they get used to it, and then do it every 2 minutes during exercise. All the commercial systems have a module that allows you to do inspiratory capacities. The 2 key things are trying to make sure there's a good baseline of that tidal volume before you do the IC, and then also having your tech go at the end of the study back and actually do the quality check to make sure that there is a good baseline measurement of the tidal volume before the IC was done, because you'll get abnormal numbers. But if there's dynamic hyperinflation, the inspiratory capacity should be going down. So think about here, this is the FRC, this is TLC. So TLC is your total lung volume, FRC is here. And your inspiratory capacity is the difference between those two, okay? So if my FRC is coming up and I can't make my lungs any bigger, the IC is getting smaller during exercise, okay? Now, what happens in normal people is your FRC actually goes down, and your tidal or your TLC stays the same. So your inspiratory capacity actually goes up in normal people, and it goes down in people that have obstructive lung disease, so asthma and COPD. It's not very helpful in normal people. It's not very helpful in non-obstructive lung disease. So like say they have restriction and things, ICs are not really going to help you much. But for obstructive lung disease, they're helpful to detect dynamic hyperinflation. And remembering rapid ventilation actually decreases the amount of expiratory time. So slow, deep breathing is actually what prevents dynamic hyperinflation. So when people with obstructive lung disease come in the emergency room and they're uncomfortable, part of that is the tachypnea of the dyspnea, and that's what's causing some of the dynamic hyperinflation. It's also true of ventilators, that if you don't have enough expiratory time on a ventilator, ID ratio, meaning a high expiratory ratio, you'll get dynamic hyperinflation in the patient as well. So dynamic hyperinflation happens in the exercise lab, happens in the hospital, happens in the emergency room. It's something that's important to pay attention to, and measuring ICs during exercise is easy on the commercial systems, and it as long as you do a little quality check of the individual measurements, it's a good way to assess dynamic hyperinflation.
Okay, sorry, we go a little bit over time if we planned for 1 hour. We still have 9 questions. I think this should be doable by Professor Stringer to answer in
Yeah,
another 10 minutes. And I
I'll
think
answer
then
them
we are done.
shorter. How's that?
I tried to do it polite, but I think you're doing a great job. Does threshold, is there a difference in thresholds if you do the exercise test on a cycle ergometer compared to a treadmill?
Yes, absolutely. I don't have time to go all the way through it, but the answer is yes. Specifically, the AT actually occurs earlier on a bike than a treadmill. And so it actually protects the patient from hypoxemia. We actually talked about this during one of the webinars. So it's important to remember that different ergometers give you different physiologic outcomes. So, for instance, if you want to evaluate somebody for a heart transplant, you want to use a treadmill because that's going to give you the highest peak oxygen uptake. But if you want to evaluate somebody for desaturation, you actually also want to pick an ergometer that's most likely to give you desaturation. So it depends on what you're after with the exercise test, and it also depends on the type of ergometer that you're going to use. And ideally, your lab should have both a cycle and a treadmill, so you can do both of them once, but that isn't always possible. So just remember that there are differences. And so it's ideal if the patient had come back in after a study previously and it was done on a treadmill or a bike, the ideal thing is to repeat that on the same ergometer so that you can know that it isn't a difference in the ergometers, it's really a difference in the patient. But peak oxygen uptake, AT, ventilatory equivalence, there's a large number of differences between treadmill and bike.
Okay. What is the clinical content of VT3? We also get a lot of this kind of questions. We have VT1, VT2, you cover them, and there's also something like a VT3.
Yeah, there's a literature on that. I have to say I'm suspicious whether it means much of anything. Maybe that's heresy, but VT3, VT4, I don't pay much attention to. I'll leave it at that. VT1, VT2 are the important ones.
I know from Professor Agostoni, he calls it hot ventilation to get rid of the extra heat like dogs do. That's the only I learned for the last several times I heard him speaking about this. Would you use, oh, sorry. Yeah, go on.
If Dr. Agostoni says it's true, it's true.
Would you use RER to assist in determining if a participant had reached his maximum if they have a low oxygen peak associated with heart failure? I think you already give a little comment on RER.
Yeah, I wouldn't use RER if I could help it. I would use cadence. But, heart failure patients are tough on the bike. They don't last too long, and you want to try to make sure that they're safe. So pushing a heart failure patient or a pulmonary hypertension patient sometimes can be a little challenging, but remember you have an enormous amount of data to make sure that they're safe, saturation, gas exchange, EKG. So I think trying to get a good study and making sure it's really represents the physiologic information of that patient is very important during the study. If there's only a tech in the room, no physician, it's harder to push the patient. So that's part of the reason I think that having a provider in the room is very important to make sure that the test is optimal for the clinical question.
Regarding the blood gases, do you recommend an arterial line? Maybe also regarding a continuous blood pressure measurement possible?
Yeah, the direct measurement of arterial blood pressure is slightly higher, and obviously it's very reliable, but it requires a transducer, et cetera, on top of drawing the blood. And then every time you draw the blood, you're going to interrupt that data. We usually measure blood pressure non-invasively, and I think that's good for most of the patients. The correlation is quite good. But if you want to measure it precisely, clearly invasive test is a way to do it with a transducer. If you're comfortable doing that, your tech's comfortable putting in art lines, or your provider, I think it's a good way to do it. But it's not the way most CPETs are done these days.
What if the predicted oxygen uptake is less than 20 milliliters per kilogram based on their demographics? How do you extrapolate for the risk for assessment for surgery?
Well, so there's if 20 mils per kilo per minute is considered good, 15 is increasing risk, 10 is high risk, 5 is very high risk. So it's not only the results of the CPET that tells you whether you should go to surgery or not, it's the acuity of them needing surgery, right? So if somebody comes into the emergency room on a trauma run, you're not going to do a lot of preoperative evaluation. They need to go to surgery, right? As opposed to somebody that maybe has a lung nodule and you want to excise that lung nodule and make sure that they're going to be fine post-operatively. You've got plenty of time to plan that. And the risk benefit of doing more planning versus the outcome of that patient is worth doing. So I think when you have a lower number, let's say the patient's 14 mils per kilo, but they have a very aggressive looking abnormality on CT scan, or the bronchoscopy shows it's malignancy, you're going to have a risk-benefit discussion. And usually that's done with a multidisciplinary conference, but it also should be done with the patient. You know, look, this is not a low-risk procedure, but this tumor is very high risk, and we believe it needs to come out, and have a discussion with them about the risk-benefit. There's very possible there's going to be complications because of this low peak oxygen uptake. So I think having a discussion with a multidisciplinary group, and sometimes the surgeons will say, yes, we will do it, or no, we won't. And then sometimes even if the surgeon says they want to do it, the patient may say, I don't want to take the risk. I'll switch to chemo or radiation or biological therapy, et cetera. So I think it has to be a shared decision-making between other providers and the patient when there's higher risk. If it's low risk, you can reassure the patient that it's likely things will go well. But of course, you know, nobody's crystal ball is clear. Just having a peak oxygen uptake doesn't tell you there's not going to be other issues or complications. So a shared decision-making is, I guess I'd leave that way.
Another 4 questions, so we are a little bit on schedule. You say an arterial blood gas is the gold standard. How do you view earlobe blood gas?
Yeah, so there's heated hand veins, there's earlobes. Most of those are used in sports physiology, but I think it's basically arterialized blood, so it's going to be a mixture of venous and arterial. If you're drawing out of an art line, you know it's arterial. If you're doing earlobe or you're doing heated hand vein or other things, there's a mixture of arterial and venous blood. So it's less accurate, but it actually is some number. It's more helpful for probably pH and PCO2 than it is for oxygen. But both of them sometimes will give you the answer. But I think if the patient's coming in and they want an answer to a specific question about their VWT or their low end tidal CO2, it would be better to do one art stick in the middle of the study and get it over with. They don't have to have an art line. You don't have to be doing stuff for trying to draw blood from earlobes or heated hand veins, et cetera, because those all can be a little tricky. We've done all those, but they can definitely be tricky.
Yeah, and I understood there is a difference in normal values. You cannot compare the oxygen pressure from an arterial. There is some, that's what I heard or remembered doing this kind of medication.
That's absolutely right. So remember, once the oxygen in the arterial system is mixed with venous, the oxygen saturation and the PO2 is going to be lower than an arterial value. So you have good predicted values for arterial blood because you know it's arterial blood. In the heated hand vein or the earlobe, there's a mixture of arterial and venous blood, and you don't know how much exactly. So PO2 is going to be suspect, saturation is going to be suspect, but pH and PCO2 are actually going to be pretty close between the arterial and venous system. So it's a good way to look at CO2 and a good way to look at pH, and maybe not so good way to look at oxygen. Depends on your question.
Yeah, and you mentioned it several times, but to be sure, do you recommend a mid CPET blood gas during anaerobic threshold VT1 better than even at peak exercise? Or if you
well, if you've tried to draw blood during peak exercise, you know it can be tricky. Sometimes it happens, but sometimes you have to do a couple of sticks to get the blood. And so the patient's struggling at the end of exercise, they're gripping the handlebars, they don't roll their arm over to where you can get a good access to the artery. I think it's much better to do it in mid-exercise. And if you can anesthetize the skin even before exercise, that's another way to make it easier for the patient to draw mid-exercise. So you can explain that we're going to do a blood draw, and that won't interfere with peak exercise, because those numbers, peak exercise numbers are important for us assessing what's going on with the patient. So if that's affected by the blood gas, i.e. they stopped because of the blood gas, they didn't stop because they had finished their peak physiologic output, that's not good.
Regarding the pedaling RPMs, what do you recommend? 55 RPMs or 60 or higher than 60? So in the past, you should be above 60. I think the more modern bikes are a little bit less RPM dependent.
Yeah, so I think somewhere between 55 and 65 is good. We try to encourage at least 60. You'll see cyclists that want to do 80 or 100. The most important thing is whatever they pick to stay on that. You don't want them speeding up and slowing down. It's going to affect, again, what the ergometer is going to show you in terms of work rate. But a lot of the bikes these days actually, if you slow down a little bit, there's a little more work. If you speed up, there's a little less work. So they're actually balancing that. So in the range of probably 60 to 70 RPMs, I don't think you'll have a problem in terms of varying work rate on most of the commercial systems. And Herman can comment. He knows more about their bikes than I do.
There are people still asking questions. Do you have a recommendation of the best treadmill protocol for heart failure patients?
I don't, but what I recommend is starting with a very low intensity, because a lot of times when they start walking, they're already above their anaerobic threshold. So we use what we call a linearized treadmill. It's the Prognosis protocol. We actually talked about that in the second webinar. There's an article you can pull by Prognosis. It's called the Linearized Treadmill Protocol. And if somebody's interested, I can send them a copy of the paper. And we also have a spreadsheet that allows you to calculate it. But essentially what it does is it starts with a very low work rate, and it goes up just like a bike does with a ramp type pattern. And that ramp type pattern starts low enough that you'll be able to catch the anaerobic threshold. So if you start at a fast work rate, either walking or incline, you may miss the anaerobic threshold in the middle of them just warming up because their heart failure is severe.
Okay, thank you. Last question. Without taking a blood gas, what do you consider a desaturation if you look at pulse oximetry? And does it matter? It's more my question from sea level, Netherlands, Amsterdam. Is it different on altitude or?
Yeah, absolutely different. So the barometric pressure is different at altitude. So there's still 21 oxygen molecules per 100 molecules, but as you go further up in altitude, they're further apart for each other because the barometric pressure is reduced. So the saturation in like say the Mile High City, Denver, is going to be closer to 90 or maybe even 88%. So sea level should be, in mid 90s easy. So the starting saturation and the movement from the starting saturation is more important to me than the actual number. So it depends. We do have CPET labs that we work with that are at altitude, and you'll see the end-tidal O2 and CO2 partial pressures are different. They're lower because of the barometric pressure and the alveolar gas equation. So it's important to remember that saturation is dependent on altitude. And most cities are not much higher than a mile, but there are some. And so doing CPET at sea level probably has the most information and the most documented normal values.
And then the difference, it's more what I recommend, it's 4% change of saturation is considered to be desaturation.
Yeah, exactly. So it's where they start, and then the change from that is much more important than the actual number. So,
thank you. You again answered 23 questions live, and I'm happy to say we don't have any questions anymore, or I don't allow them. but I will do my best within VAR to reschedule this kind of webinars in the future. I cannot say when, but I think they're very helpful. I have to say, everybody who attended for this 1 hour can have the CCRE accreditation points regarding to this webinar. And with this, I have to close this, again, very informative webinar. Excellent done by Professor Stringer. Thank you from my side. Thank you all for attending, and hoping to see you in a few weeks. We have another educational webinar about lung volumes, also interested. What do you want to
Sounds
say?
good. Thank you, Herman, and thank you everybody for coming. Thank you, Claudia, for all the help. Hope to see you all soon at a meeting or something.
Yeah. Thank you. Bye.
Bye-bye.
Bye.